This is chapter 29, part 2. Let's talk about the physiology of electrolyte balance. So the big electrolytes that we discussed are potassium and sodium. Now we did talk about these in diuretics quite a bit. They are the ones that we see meaningful fluctuations with. That means things that we're really concerned about. Electrolytes are measured in milliequivalents, and sodium and chloride are going to be our principal extracellular electrolytes. That means they're outside of the cell. Potassium is the principal intracellular electrolyte. So your potassium level, and I do want you to know this, a normal potassium level is 3.5 to 5. Your excessive dietary potassium is going to be excreted in the kidneys by the urine. That means somebody with renal failure may have difficulty excreting potassium. Here is an area in your HESI book that you can look at. Drugs that cause low potassium that we just talked about are loop diuretics and thiazide diuretics. Now, other things that can cause potassium to be low are things like diarrhea and vomiting, tube drainage. Steroids may do that, as well as aminoglycoside antibiotics. One thing to note here that may be helpful for you moving forward is that if someone has hypokalemia, so for any reason they have hypokalemia and they are taking digoxin, remember the cardiac glycoside digoxin, a patient with hypokalemia who is taking digoxin can experience digoxin toxicity. Now, this does not mean somebody who takes digoxin will have hypokalemia. This means somebody who has hypokalemia for whatever other reason could experience digoxin toxicity. Now, there are different types of potassium supplements. We can give oral, liquid, or IV potassium. We can take potassium in pills. The pills are typically very large. We can take it in a liquid or IV potassium. IV potassium can be pretty caustic to the veins and can be irritating. When someone is taking PO potassium, if it is a sustained release capsule, we need to follow our regular guidelines that we know. Anything that is sustained release we should swallow whole. It can cause GI or ulceration if we chew it. We can overdose when we chew. So be mindful of that with sustained release potassium and any other sustained release drug. Now, IV potassium needs to be administered very slowly. If IV potassium is administered too rapidly, it can result in cardiac arrest. You would never, ever, ever under any circumstance administer potassium as a bolus. That is a very important safety issue I need you to know. Now, there are different recommendations, and I'm sure your policy will have some recommendation. But the principle to know here is that you would administer potassium very slowly. That means your patient would be getting probably 10 milliequivalents per hour or less if they are not on a cardiac monitor. Remember, that's a few stickers on the chest where we can see the electrical activity of the heart on a screen. Now, if somebody is on a cardiac monitor, we can give the potassium a little bit faster, but that's because if somebody has hyperkalemia, they can get electrical rhythm disturbances. We need to monitor that. Just a note here, potassium as a bolus is administered patients who are prisoners who are going through execution. So I want you to grasp how big of a deal it is to administer potassium slowly. All right, the primary healthcare provider prescribes a dose of IV potassium chloride for a client. When administering the IV potassium chloride, which action should the nurse take? Should the nurse administer it as a bolus, use a filter in the IV line, dilute it per medication instructions, or apply a cool compress to the IV site? So we're going to dilute it per medication instructions. So that's not a concentrated amount of potassium that's going into the patient. It's a small amount, diluted amount going into the patient. So drugs that cause high potassium or potassium-sparing diuretics such as spironolactone or ACE inhibitors. Remember, ACE inhibitors can cause elevated potassium. With hyperkalemia, this is a potassium level greater than 5. To manage hyperkalemia, and I don't need you by any means to memorize exactly which level correlates to which drug, but if a patient has a mildly elevated potassium level, they may have a dietary potassium restriction, so to eat less of foods that contain potassium. If it's a little high, they may be administered oral or rectal polystyrene sulfate, which is K-exalate. K-exalate binds with the potassium in the body and excretes it rectally, so the patient has stool that comes out with potassium in it. The patient may also be administered a cocktail of IV medication. They may be administered dextrose to keep their sugar high. We're at an appropriate level because we would administer insulin. Insulin takes the extracellular potassium and moves it inside of the cell. That'll lower our potassium level. Hyperkalemia also causes an acidotic state. Remember, that's a pH of less than 7.35. So we would give sodium bicarbonate. That actually pulls the pH up to a normal range. And then we would also give calcium. Now, calcium protects the heart. Calcium protects the heart and prevents, hopefully, that abnormal electrical activity that comes with hyperkalemia. And then if it's very severe, the only way to get that potassium down is to dialyze the patient. That means take them to dialysis and filter their blood out of that potassium. Okay, a client with hyperkalemia is prescribed sodium polystyrene sulfate, which is K-exalate. Which serum potassium level is a clinical indicator of effective therapy? So this is a potassium level. Is it 4.9, 5.4, 5.8, or 6.2? So you have to know your normal potassium level in order to answer this question. So it is 4.9. Now let's talk about sodium. Sodium is our main extracellular cation. I do want you to know our sodium levels. So our sodium levels are 135 to 145. Hyponatremia is below 135. This can be caused because of diuretics. It can be caused by carbamazepine, which is an anti-epileptic drug, amiodarone, which is an antidysrhythmic, or SSRIs, which are a medication for depression. Now, to deal with hyponatremia, we may limit fluid. If we limit fluid, we're going to hold on to sodium. We could give a sodium tablet. Moderate hyponatremia, we may give IV fluids, isotonic IV fluids, sodium chloride, or lactated ringers. For severe hyponatremia, we may give hypertonic fluid. So we may give something like 3% normal saline. Now, this is a high-risk treatment due to the risk of irreversible brainstem damage if the patient receives this too rapidly or too high of a dose. The next one is hypernatremia. Hypernatremia is anything above 145. Now, sodium is only known to interact with one antibiotic. The brand name is Sinersid. So that means sodium chloride would be compatible with all other medications except for this antibiotic. Now, one thing to note about giving IV medication is that your IV, wherever it is placed, cannot be on the side where a patient has had a mastectomy, which is breast removal, or a removal of lymph nodes on that side, typically due to cancer. If a patient has had a stroke on one side of their body, you would avoid those sites and place the IV in the other arm.